Good morning, everyone. I'm sure there'll still be some people joining, but let's go ahead and get started. There's a lot to talk about today. So I'm really happy to be able to introduce today two faculty from the University at Aarhus in Denmark. First, Dr. Vera Ehrenstein. She got her master's degree in MPH from Boston University in epibiostat and her doctorate there as well from Boston University. And she's currently a professor of pharmacoepidemiology in the Department of Clinical Epidemiology at Aarhus. I'd also like to introduce Dr. Horváth-Puhó. She has her master's degree in mathematics and her PhD degree in health sciences. And she's an assistant professor also in the Department of Clinical Epidemiology at Aarhus in Denmark. And they're going to be speaking today about some of the data available and the possibilities for clinical epi and social epi and all types of analyses using Danish data. I've worked with at least three students over the years who've gone to Aarhus and had a number of really successful projects and collaborations with investigators there, really doing work that you can't do anywhere else in the world. And for a lot of epidemiologists are aware of this, but if you there's a lot of kind of clinical questions and social epi population health questions that really are best answered with this data. And we feel really fortunate to have this collaboration at Stanford and PHS with folks at Aarhus University. And so without any more background from me, I'm really excited to hear your talks today, and I'll let you take it away. If you have questions, please put questions in the Q&A box, and we will cover those at the end of the talk and should have a good at least 10 minutes for those questions. So thank you again both for being here today.
Thank you, David.
Thank you so much. So we have a teamwork with Erzsébet. She will help advance the slides, and I'll do my best to talk. So thank you, first of all, for the opportunity to present this topic that I really like to talk about. I have worked with Danish data for more than 20 years now. As you have heard, I have completed my doctorate in epidemiology at Boston University. However, the data for my doctoral project came from these Danish data. So we were doing real-world research using real-world data, even before that term existed, before it was introduced. And just to show you, there were a couple of popular articles in the Science magazine by the Danish journalist Lone Frank. One of it was called When an Entire Country is a Cohort, kind of speaking to the epidemiologists in us. And another piece by the same journalist was called Denmark, an Epidemiologist's Dream. And so it seemed appropriate to take this as a title of today's presentation. And what we'll do is I will give you a very quick run through the data that are available from Danish registries, and I will only scratch the surface. I will give you an overview of data sources that we use most frequently, but there is a lot more, and the possibilities are really endless. Next slide, please. So where is Denmark? If you look at the map of the world, Denmark is a very small country. It is located in Northern Europe, right under the Scandinavian peninsula. You can almost not see it on the map, but it's a country with a large research influence thanks to its wonderful data. There were some research papers, review papers published summarizing the amount of person time that accumulated in, let's say, some of the insurance-based US databases from the little pieces of person time contributed by each person, and then the person time accumulated in the Danish registries over the years, with each person contributing the entire lifetime. And in fact, the amount of person time in those two types of data sources were comparable, despite the fact that Denmark is a country of only 5.8 million people. So next slide, please. As already mentioned, the population of Denmark is almost 9 million. And there are several really unique features that make Denmark what we say an epidemiologist's dream. First of all, the residents of Denmark enjoy a single-payer tax-supported healthcare for all its residents. And that includes visit at the general practitioner, and the general practitioner in Denmark is the gatekeeper between the patient and the access to specialist care. There are some exceptions, such as emergency room visits, dental visits, and some others. So the healthcare also covers the visits at specialists after a GP referral, and also admissions to hospital for hospitalization stays, and also specialist outpatient clinics. So a part of the cost of all drugs is also paid by the Danish healthcare system. So that's one feature. The other feature is that every time a person immigrates to Denmark or is born in Denmark, that person is assigned a unique numeric identifier. And that has been in force since 1968, when the Danish Civil Registration System was established. So this number is unique. It follows a person from cradle to grave, and it is used in all data sources. So you can imagine that you can link data from all data sources, including routinely collected data, but also data collected based on bespoke studies. So currently, the CPR number is a 10-digit number, and it encodes a person's date of birth with the first 8 numbers, so month, day, and year, and then there is the last 4 numbers is a serial number that is unique. This number also encodes a person's biological sex with odd numbers for males and even numbers for females. It's currently like that. So, and then you have these data sources, you have a single payer healthcare system, and then you have these registries. And the picture that you see on your screen now is from one of our publications. And it shows several different registries, but again, as I said, it really is just scratching the surface. There is a lot more. So, and we can link data from all those registries. The Civil Registration System, which I just spoke about, thank you so much. It really provides information on the date of birth or immigration or death or emigration, so you can really follow each person from birth to death, and you can also construct an open cohort of the Danish population where you can register each time a person was in Denmark and out of Denmark, and you can create the analysis based on person time that way. So the next registry is the Danish Medical Birth Registry. That's also one of the major registries that we use. It has one observation per live birth or per stillbirth after the 22nd week of gestation. So it has some basic obstetric variables recorded for the mother and also for the child, things like birth weight, gestational age, UPGAR score. And for each child, it has also information on mother's identifier. So you can link information on the mother to the information of the child, and so on. You can do multi-generational studies. You can study exposures in parents, grandparents, and outcomes in children and grandchildren. So the next registry that we use very often is the Danish National Patient Registry, and it is a registry that has one line per patient, per visit, per date, per department. Again, the unique identifier is used in this registry, and it is a collection, just like many registries represented here. It is a collection of relational tables. In this registry, for example, one table contains information about administrative details of an admission, such as dates of admission and discharge. Another table contains diagnosis, yet another table contains information about procedures and some of the medications administered in hospitals. The next registry is the National Prescription Database, and in fact, it should probably be called the National Dispensing Database. This database has one line per patient per dispensing per date. So it records dispensings of by prescription medications that were, so prescriptions had to be dispensed in outpatient pharmacies. It's sort of a standard set of information that is recorded by this registry, including the package that was dispensed, the amount of number of units in the package, and so on. So you can construct, for example, in pharmacoepidemiologic studies, you can construct trajectories of use and switches and initiation and discontinuation of prescription medicines. So these ones that you see right now, I call them our daily working horses. We use them in nearly all the studies, and you can imagine that you can construct pretty much all health histories of a specific disease that you study in clinical epidemiology. So one maybe limitation that I could mention is that diagnosis in primary care are not so far recorded in Denmark. However, we can, for example, for chronic diseases, compensate for the lack of that information by including information about a drug proxy. So if we want to identify patients with diabetes, we would identify them by using anti-diabetic preparations. And then I saw already we had the hospital medicine register. This is a new addition, and I hope we will use it a lot in the future. It is available for research starting in this year. This is a unique source of data because it records medications administered during hospital stays. And so the data look very similar to the way they look in the prescription registry, including the amount dispensed and potentially also the exact time of the administration of the drug. This is very important for example, cancer research in Denmark, because cancer medicines are administered in hospitals, but also a lot of newly approved expensive medications usually start in the hospital, start at outpatient clinics that are located in the hospitals. So, for example, for my pharmacoepidemiologic research, it's very important that we have those data. So the next set of registries I would like to highlight are the ones that contain information about biological samples, if not biological samples themselves. And a fantastic data source is the Danish National Pathology Registry. It has been in use since early 90s, and it contains diagnosis made in all Danish pathology departments. I will talk about this a little bit more in the next slide, but things that this registry could be good for include biomarkers in cancer patients. We have done some studies in lung cancer patients, in breast cancer patients, in colorectal cancer patients. And then the other registry I would like to highlight, which is also quite unique, is the Danish Laboratory Test Database. It used to be a regional database, but since a few years, it has become a national database. So it contains results of all routine laboratory tests performed at hospital laboratories. However, it also includes tests that were sent, let's say, by GPs to hospital-based labs. So it also has some outpatient lab information. Next slide, please. So, and then what is probably less known to the general public is the availability of the Danish biobanks. So biobanks are structured collections of individual level biological specimens. So we have collections of the biological material. So biobanks can be used to understand disease etiology, to advance precision medicine to do studies in epigenetics, genome-wide association studies. I'm sure you can imagine all types of different research that can be done using biobanks. Just like registries, biobank samples are stored and organized according to the CPR number, to that personal identifier. And so you can link all the clinical data in the registries, including family data, cancer data, hospital admission data, medication data, to those biobanks. So since this group is interested in social epidemiology, we don't have slides specifically on social registries. I think Erzsébet has some examples of social epidemiologic studies. I'm just going to mention briefly that we also have, Denmark also has nationwide registries on a number of socioeconomic characteristics of the population, including income, education, and grades received in school. So next slide, please. So I just talked about Denmark just now. We also have a lot of collaborations with other Nordic countries, Finland, Iceland, Norway, and Sweden. They all have a rather similar systems with the same standard, I should say, set of registries of hospital admissions, dispensings, births, and the population registry. So they're all linkable, just like Danish registries are, and together they cover a population of about 27 million people and in the Nordic countries. I have to say, Danish data are, in some respects, are richer than some of the data in other Scandinavian countries. So, but we do have experience and collaborations working in multinational setting with Danish and other Nordic countries. And you will have some references to, if you want to read up on this. Yes, it can go to the next one, Erzsébet. Thank you. So these two papers probably give a very good overview of what is possible. So the one on the left describes the Danish healthcare system and the epidemiologic research conducted within that. It shows you how the point of care in Denmark is translated into a data point in a given database. And the paper on the right provides sort of a more high-level overview of the same topic for the entire Nordic system. So next slide, please. So we often get questions, how do we access the data? So whenever we have a project, we need to go through certain well-defined steps, and we can access the data. So first of all, you need to register your project with the Danish Data Protection Agency, and that is with the advent of the General Data Protection Regulation in the EU. has actually become somewhat easier than it was before. That is done for us by Aarhus University. So we need to have a record of registration with the Danish Data Protection Agency. And then we have to prepare a set of standard documents, which include project description and the data specification that has to align with that project description. We access the data on what we call a research machine. And research machine is available in two governmental agencies. One is the Danish Health Data Authority, and the other is on the Service of Statistics Denmark. So those of you who have participated in collaborative projects with us probably have access to the data on Statistics Denmark. And the reason for that is that they host data on socioeconomic registries. So it is a role-based, secure access to the servers of these two governmental agencies. And we log on to their servers and we do data analysis there. And we can take out aggregate results. We cannot download what we call microdata or individual level data, but we can do all the analysis on those servers and extract aggregate data. Next slide, please. I think this is the end of my presentation, and I think the most exciting part comes now with examples of the actual studies based on these registries. Thank you for your attention.
Thank you, Vera, for this interesting presentation. In the second half of our presentation, we would like to show you a few use cases based on the Danish registry data. In the past decade, our department has established fruitful collaboration with many research groups from Stanford University and developed together several research programs. Among the key collaborators are Professor Arnold Milstein from Clinical Excellence Research Center, Professor Victor Henderson from Department of Neurology and Neurological Sciences, who is here with us today, Dr. David Rakob from Stanford Center for Population Health Sciences. Thank you, David, for inviting us to give this talk today. And last but not least, we have collaboration also with Dr. Matthew Baker and his research group from Division of Immunology and Rheumatology. The first example, which I'm going to present today, is a comprehensive research program within reproductive epidemiology, the so-called cost of caregiving program. And secondly, I'm going to talk about our neurological research provided by our department in collaboration with Professor Victor Henderson. The cost of caregiving program has been developed by Professor Arnold Milstein and Nirav Shah and their team, their wonderful team from Stanford University, and by Professor Hendrik Toft Sørensen, the head of our department from Aarhus University, and Dr. Eyal Cohen from University of Toronto. The aim of the program was to understand the lifelong health and economic consequences of caring for chronically ill children in order to guide targeted interventions for caregivers. As a first step, we have established a big pregnancy cohort on Statistics Denmark server, where the availability of Danish registry data allowed us to locate different generations and identify the families by using Danish registry data and linking children with the parents, so we can, as a result, have the siblings and we can the linked mother and father information in the same registry. Having a child with a major birth defect can be a life-changing and stressful event for a woman. Therefore, within this big pregnancy cohort, we identified mothers of children with major congenital anomalies. And as you can see, we've identified more than 45,000 mothers in our study period between 1980 and 2018. With the help of the medical birth registry and the Danish Civil Registration System, we were able to sample a comparison cohort from the Danish general population and include in the reference cohort mothers who did not have a child with a major congenital anomaly. The aim of this program was included a very broad range of aims. First, we wanted to assess the overall mortality in caregivers, both in mothers and fathers. We were also interested in risk of cardiovascular diseases and mental disorders in mothers, and analyze healthcare utilization of the mothers, and additionally describe the employment status, social benefits, and healthcare costs of mothers, which are through the caregiving stress. With the help of the personal identification number, the so-called CPR number, which was already described by Vera, we could link all the needed medical and administrative registries to our pregnancy cohort. And as you can see here, we linked very different and a broad range of Danish registry data. First, we linked the Danish Civil Registration System, from which we could have daily updated information on vital status. We had Danish National Patient Registry data to identify the discharge diagnosis with the help of the ICD-8 and ICD-10 codes. We also linked the Psychiatric Research Register, where the maternal mental health conditions could be identified. We had the Danish Cancer Registry, the Nationwide Prescription Registry, and also socioeconomic data was available on Statistics Denmark server. We used various proxies to define socioeconomic status, like income, education, or employment status. We linked also the registry of causes of death, the laboratory data, and health insurance registry data, which contained information from primary care visits and the costs related to these visits. Let me mention here that the data linkage is a very complex step when we are running a study. So we always try to make sure that we allocate enough time to data linkage and data management steps. Our first study on mortality in mothers who delivered an infant with a major birth defect was published in JAMA in 2016. We found that having a child with a major congenital anomaly was associated with a small but significantly increased risk of mortality in the mother compared with women who did not have an unaffected child. The adjusted hazard ratio was around 1.2. With the help of the registry of causes of death, we could also conclude that the mothers were more likely to die of cardiovascular and respiratory diseases. We found higher risk of premature cardiovascular diseases among women who gave birth to an infant with a major congenital anomaly. Mothers of affected children experienced a 15 to 37% higher risk of cardiovascular conditions over a 20 years follow-up period. Mothers who gave birth to a child with birth defect are at increased risk of new onset psychiatric disorders as well, especially shortly after giving birth, and for mothers of children with more severe anomalies. To define the severity of the congenital anomaly, we used different approaches. One of them was to differentiate those who were single and multi-organ congenital anomalies. The large sample size in this mental health study allow us to examine the risk of different psychiatric conditions such as schizophrenia, bipolar disorder, anxiety, stress-related disorder, or substance abuse disorder. Our study on healthcare utilization among exposed mothers showed greater healthcare utilization across services over a 20-year time horizon. We found small differences in use of outpatient clinic services and moderate differences in use of inpatient and psychiatric clinical services. In one of our ongoing projects, we have linked the cost data from primary sector and secondary sector registries to our cohort of mothers and tried to assess the various direct costs in the year of the delivery, 1 to 6 years after the delivery, so in the preschool years, and 7 to 10 years after delivery. As you can see in this figure, the direct healthcare costs were 19% higher in the year of delivery and 14% higher during the 1 to 6 year after delivery in exposed cohort compared to the matched mothers. So this was actually the project on cost of caregiving, and now I would like to go to the examples from the neuroepidemiology. One of our first joint studies with Professor Victor Henderson was published in JAMA in 2015. This study examined the association between pertussis infection and risk of epilepsy in children. And we also, as you can see, we included, or in this study included 4,700 cases with pertussis infection and a 10 times larger comparison cohort from the general population without this condition. On the figure, we can see the cumulative risk of epilepsy in the two cohorts over 15 years of follow-up. The results of this study indicated that the risk of epilepsy was increased among children with hospital-based diagnosis of pertussis infections compared with the general population comparison cohort. However, as you can see on the figure, the absolute risk values were very low. The next example, which I wanted to mention, is a study on stress disorders and risk of dementia. This has been developed by researchers from Stanford University, Aarhus University, Boston University. The project leader was Jamie Grados from this university, and colleagues from University of California. One of the strengths of this study was that the large sample size allowed us to separately analyze the subtypes of the stress disorders, which was a knowledge gap in the literature. So we could analyze separately the risk of dementia in patients with acute stress reactions, PTSD, adjustment disorder, and other stress reactions. And our study showed that the stress disorder diagnosis is associated with a nearly threefold increase in the rate of developing dementia. And this association was more pronounced among men, except for PTSD, which had a stronger association for women. This paper was published in American Journal of Epidemiology, and in 2019 has received the award of Article of the Year. A similar ongoing study on the association of depression with dementia includes patients with depression diagnosis identified from the Danish National Patient Registry and Psychiatric Registry between 1977 and 2018. This cohort included approximately 2,500,000 patients with depression in Denmark and 1.2 million large comparison cohort without depression. On this figure, you can see the cumulative incidence of dementia, which was around 14% over a follow-up period of 40 years. So we can see that this study has the advantage of long follow-up data, which is quite complete because we have the vital status and immigration information from the Civil Registration System, and also the large sample size is a big advantage. And this cohort size allowed us in the project to run stratified analysis by age group, so we could examine the effect of depression on dementia on early, middle, and late life depression. And as you can see on this figure, we also could repeat the main analysis among women and men. And by follow-up periods, so we analyzed the data in 1 to 10 years follow-up, 10 to 20, and 20 to 40 years of follow-up. We found that the risk of dementia was more than doubled for patients diagnosed with depression compared to the depression-free comparison cohort. The association between depression and dementia was stronger among men, and persisted whether depression was diagnosed in early, middle, or late life. And my last example is about the labor market participation after stroke. In this study, we linked to the cohort of patients with the stroke diagnosis, the Danish Interdepartmental Administrative Database, the so-called DREAM database. This dataset registers information on all public transfer payments on weekly basis. So with the help of this registry, we could create these figures. As you can see, the first three figures describe the three different stroke subtypes, and we have a fourth figure for the general population. The pattern is different, as we can see from these curves. As you can see, the study found that 2/3 of the ischemic stroke participated in the labor market 2 years after diagnosis. And this labor market participation was lower for patients with intracerebral hemorrhage and than the other stroke types. And we also found that the sick leave and receipt of disability pension were the more common reasons for non-participation in these patients with stroke diagnosis. So that was my last slide, and I would like to give back the floor to Vera.
Yes, thank you. I just wanted to finish by bringing your attention to a program and training program that is called DARE. It is funded by the Danish Lundbeck Foundation, a foundation that was established next to the a biopharmaceutical company, Lundbeck, located in Denmark, but it is completely separately from the pharmaceutical company. So DARE stands for Danish American Research Exchange. There is a website where you can find information. Henrik has been the Aarhus University liaison for the program for some years, and now I taken over from him. And now I am the Aarhus University liaison for the program. Basically, this program funds 5 Danish medical students in their 5th semester, I believe, to come to either Stanford University or to the University of California in San Francisco and do a research project in a US research lab or department. So there's a rigorous selection process. We assist students in finding a Danish mentor and a US mentor, and the students live in one house for 1 year, and they complete their research project. So I think we have one more slide about that. Yes, so in order to qualify, students need to be enrolled in the Danish Medical Master's Degree course. And they also have to fulfill certain research qualifications that are quite realistic to fulfill. I just wanted to put this on your radars because this is a great way to find future talents, and I would like to encourage all of us to maybe try to find students to supervise together, and I might contact some of you next time around, which will be around August or September of this year, if whether or not you would like to be a Danish mentor, the US mentor for one of our students. So I just wanted to bring this up. This is a great program, and that's that about the DARE. And I think there were also some questions about how to go about if you have a new study idea within the collaboration between Aarhus University and Stanford University. And this slide just outlines some steps that you need to go through. Start with a brief proposal, then get in contact with the Stanford Center for Population Health Sciences, which then the project team will develop a detailed study protocol and a statistical analysis plan. And then there are some legal basis for this collaboration. And then you will use in step 5, you will use the standard procedure I mentioned before to apply for the data at the Danish Health Data Authority of Statistics Denmark. And then the data would be extracted and analysis done, and lots of papers published. So just some some practical advice. And I think this was our last slide. We have put our contact information here, and we are open and looking forward to any questions that you may have. Thank you very much for your attention.
Thank you for your attention. So I will stop sharing now.
Thank you so much, both. Both have. I know you said that the Vera, that the research results would be the exciting half, but both halves were very exciting. Your description of the data is amazing. And I just have a quick question to start, although I have a few others about the DARE program. Is that typically students who will work on a project with Danish data with a Stanford mentor, or does it kind of depend, or typically they be using the
well, they have to have one of the important criteria for acceptance is that they need to have a reason to go to the States. So if somebody works with Danish data and sits in Stanford, that's not cutting it. There need to be an American component that enriches their Danish research. So it could be that they do some population or database research in Denmark, but they might do some supplementary lab research at Stanford or at UCSF. Or they do, they can participate in trial recruitment in the US. So we usually welcome a component that something that they can do that they cannot do in Denmark.
Yeah, perhaps a comparison with US data or replication or things like that.
Something like that.
Yeah, perfect, thanks. Great, do folks have other questions? Esther?
Hi, thanks, David. Wonderful presentation. It truly is a dream, I think, for those of us who haven't been exposed to data like that. So really appreciate you guys sharing this with us. I had some questions about the ability to look at the involvement of municipalities, especially in the studies looking at the children with congenital anomalies and the complex medical needs. Like, were you able to adjust for the municipality in which they were residing, and to what extent is the municipality kind of involved in providing social services or medical services to families?
Yeah, that's a good question. Thank you very much, Esther. So we have municipality data, we have the codes, and we can also group them by the different patterns which we observe in different municipalities. In the congenital anomaly studies, we haven't taken them in consideration like in the matching, but in some of the adjusted models, we have included region in the complex regression models, and try to control for this important factor in that way.
Maybe not exactly that topic, but a similar topic. You think you're getting at a heterogeneity of care that is determined by residents. So Denmark is a small country, and of course there are regional differences, but overall the care is quite uniform. And in medical care, Danish physicians, they adhere to the guidelines very much. And for example, in my area in pharmacoepidemiology, when we look at comparative effectiveness of specific drugs, for example, we had drugs on novel anticoagulants, it is really a high bar to show a comparative effectiveness in the setting of a very high adherence to guidelines and high standard of care that really puts you, adds value to any potential difference in effectiveness of different drugs. So that's something that could be appreciated. Sorry.
Can I ask a follow-up question about that? So would you be able to see variability in utilization of services that are outside of the direct medical care? So for instance, if there are transportation services for older adults, or food assistance, or especially programs that might be not you could actually see utilization, not necessarily like prescription of the support or like in-home caregiving kinds of things?
I think you could probably identify some of the devices that are dispensed. Yes, and disability pension would be also, you could probably identify some of the markers of that in the existing data. But Erzsébet, did you
Yes,
have to
I
add?
just wanted to add that we also have data on in-home treatments or in-home visits, so we could add that to the current healthcare utilization data. And as Vera said, we have also some social benefits, or we see the social benefits from the DREAM database on weekly basis, and based on that, we can define different categories.
Wow, great. Thank you.
Daniel, I think your hand was up first.
Yes, very exciting work. Thank you for the presentation. It's a shame that we don't have a similar national birth to death registry in the United States. Nonetheless, I'm interested in how you record and the availability of vaccination data for HPV and the effect that the pandemic had. So do you have uniform data on every patient's vaccination for various diseases?
Yes, so it varies. So for vaccinations that are administered at GP offices, so the routine vaccinations such as HPV or the childhood vaccines, or vaccines, basically all vaccines that are paid for by the National Health Service, we can identify them in the Danish Health Service Registry. And there is also a Danish vaccination register that identifies all those vaccines. We sometimes cannot capture vaccines that are done for traveling, so something for which patients have to pay themselves. We are running a European study of Moderna vaccine right now, and we are able to identify all of the administrations. It's a subset of the Danish vaccination register. We're able to identify that, and in fact, one of our colleagues, Ryan Thompson, he has conducted two kind of seminal studies on COVID-19 vaccines, identifying the potential side effects in Denmark and in Norway. And he also did a few studies on HPV vaccinations using these data.
Oh, he's looking at the effect. If you get one vaccine, did you more or less likely get HPV, or if you went and got COVID? I'm concerned in this country, we've fallen behind on our routine vaccination, but we don't have a national registration to know HPV vaccinations or COVID vaccinations. And so it'd be nice to see on a national level what effect the pandemic had on a very effective anti-cancer vaccine, HPV.
You could monitor vaccination rates.
So we would have, that would be something.
Yeah.
Thank you.
Yeah, to Daniel's point, I was thinking for my next talk, I'd title it The United States an Epidemiologist Nightmare. So we could just. Sun, did you have a question?
Yeah, thank you for the presentation. Yeah, in next live, I really have this dream to be born as a biostatistician in Denmark. So thank you so much for the presentation. It's really good to know about the data set in Denmark. So I have two questions. First one, maybe you mentioned it, I missed it. Please forgive me if that's the case. I wonder if there is any data set about the provider where the detailed information about providers is available, so that we can link that data set to the data set they introduced. Second question is about some nationally representative survey data where we can find some rich information about social determinants, and also we can link to the data files that you mentioned. For example, if we want to look at self-reported neighborhood or community context of health, or self-reported utilization and accessibility to healthcare. I wonder if there's any data set we can use and link to the data set you mentioned in the slide. Thanks.
I think in regard to your second question, we can say that we have some good survey data in Denmark. We have one survey on social variables. It is called How Are You survey, which is a national health survey and includes many information on isolation, socialization, and all the lifestyle factors which we cannot capture quite good in the registry data. So we have information on BMI, smoking, alcohol consumption. And I think that survey might be a very good data source to link to the registry data and find out the information on the needed factors from that survey.
Yes, just to add to that, we published with UCSF colleagues, we published a paper on social isolation and mortality using the survey. So basically they can be cohorts that you can follow forward with the registry data. They're also routinely collecting information on SF36 and some of the validated instruments. In terms of provider identity, the way we go about that is we have primarily diagnostic data from hospital encounters, and there we have a hospital specialty, department specialty. So this is how we do that. We also have the Danish Health Service Register that I just mentioned, and that does not record diagnosis, but that records services provided by certain specialists. So there you can identify those. For example, one of our students has done a study on antidepressants in pregnancy, and she could use psychotherapy as a comparator for pharmacological depression therapy in one of her studies by identifying contacts with psychiatrists or psychologists. So we have ways to identify providers both in secondary care and in primary care.
And just one additional note, I can confirm that it is really nice to be a biostatistician in Denmark.
Oh God, yeah.
And the epidemiologist.
Thank you.
Any other questions before we go? Great. Well, thank you both. And this is recorded, so we'll be able to give access to more people who weren't able to attend right now. And I'm sure many people will also be interested in this who couldn't attend today. Thank you so much for your time, and really looking forward to more collaborations with you and continuing these projects. So I look forward to being in touch. Thank you so much. Bye.
Thank you.
Thank you very much.
Bye-bye.
Bye-bye.